Hello everyone, welcome again to this brand new video series on ECG clinical cases. In this video, we are going to demonstrate important ECG finding and important clinical entities. We are going to begin with myocardial infarction, ECG finding in myocardial infarction in the distribution of different vascular territories of the heart. Then we are going to talk about ECG finding an important electrolyte imbalance like hyperkalemia, hypokalemia. We are going to talk about some rhythm problem. We are going to discuss bradyarrhythmias, various type of heart blocks, and also we are going to talk about tachyarrhythmias. And in tachyarrhythmias, we are going to talk about specifically about supraventricular tachycardia, ventricular tachycardia, and other type of tachyarrhythmias. Then we are going to switch our mode toward some congenital heart disease, ECG finding in some congenital heart disease like hypertrophic obstructive cardiomyopathies, arrhythmogenic right ventricular tachyarrhythmias, and also we are going to talk about Wood-Parkinson-White syndrome. Also, we are going to talk about some ECGs, important ECGs finding in various type of toxicologies cases like tricyclic antidepressant poisoning and other type of poisoning. So this is a whole lot series of videos, and today we are going to talk about ECG finding and myocardial infarction, and specifically we are going to focus on different vascular territories in each cases. All right. So let's begin with our first case. This is a 45-year-old patient, non-hypertensive and diabetic, now presented to us with chest pain and diaphoresis. His BP dropped to 80/50 following sublingual nitrate. So this dropping of BP following sublingual nitrate point towards something, and I'm sure you know it. I'm sure you're smart enough, you know it, but let's wait for the ECG strip. This was the ECG done on arrival to ER. So let's interpret it together. And the way I do it is first look at the rhythm, whether it's normal sinus rhythm or the rhythm is originating from somewhere else. So just look at the strip and see if every QRS complex is preceded by a P wave. If the P wave is upward in lead 1 and 2 and it's inverted in AVR, and the PR interval is constant throughout the EKG strip, then you're right. You are very right. The rhythm is normal sinus. Each QRS complex preceded by P wave. The P wave are upward in lead 1 and 2 while it is inverted in AVR, and the PR interval constant throughout the EKG strip, then the rhythm is normal sinus rhythm. And so is the case here. You can see every QRS complex is preceded by the P wave, upgoing P wave in lead 1 and 2 while it is inverted in AVR, and the PR interval are constant throughout the EKG strip. So you can rightly say it here, the rhythm is normal sinus rhythm. Next thing to do is to calculate the rate. And I will do it, so the way you do it is to count the number of small boxes between two QRS complex. So let's count here. It's almost 17 or 18. So now you took 1500 and divide it by the number of small boxes between two QRS complexes. So here 1500 divided by 18, it's somewhere around about 84 beat per minute, and it's regular. Next thing is to look for axis deviation. And axis deviation, you can calculate the axis by looking at lead 1 and AVF. If the QRS complexes are predominantly positive in both lead 1 and AVF, then yes, you are looking at the normal axis. The axis is normal. If the QRS complex in lead 1 is positive while in AVF it's negative, then that is possible left axis deviation. While if QRS complex in AVF is positive while it's negative in lead 1, then it is right axis deviation. And if QRS complexes in both lead 1 and AVF are negative, then this is extreme axis deviation. So here you can see QRS complexes are both positive in lead 1 and AVF, so it's a normal axis. Next thing you do is to calculate the PR intervals to look for any evidence of heart blocks. And normal PR interval is somewhere between 3 to 5 small boxes, or 0.12 to 0.20 second. So here you can see, if you look at the upsloping of P wave to the beginning of QRS and calculate the interval, it's somewhere 6 boxes, which is more than we can anticipate in a normal PR interval. So there is some evidence of first degree block on this EKG strip. Next thing you do is to look for Skt changes. So you can see it's very much obvious. There is ST elevation in lead 2 and 3 and AVF, the inferior group. And there is some reciprocal depression of ST segment in lead 1, V5 and V6. Well, V6 and AVL, the lateral group. Next, you can also appreciate some degree of ST elevation in lead V1. It is also quite significant in the setting of inferior wall MI. It points towards something which is very common with inferior wall MI. You're right, RV and fault. So now I will finalize my finding on this EKG strip. Normal sinus rhythm with a rate of 84 beats per minute and regular rate. There is PR prolongation, first degree heart block. There is ST segment elevation in 2, 3 and AVF with reciprocal ST depression in lead 1 and AVL. There is ST elevation in V1. And you can also appreciate that ST elevation in lead 3 is quite greater than that in lead 2. So it's also pointing toward RV and fault, possible RV and fault. So now this EKG strip has shown me that there is ST elevation in lead 3 and 2 and AVF with possible evidence of RV and fault. So now I'm going to confirm that whether RV and fault is definitely there or not. So the way I'm going to do it is to record an EKG while using right-sided chest lead. So here is the EKG of the patient with right-sided chest lead. So if there is R wave NV4 and right-sided chest lead, I definitely confirm my right-sided RV and fault. So you can appreciate there is R wave and I have marked it. So there is R wave NV4, so it confirmed that there is RV and fault. What are the clinical significance of right ventricular infarction? All of you know that right ventricular infarction complicate up to 40% of the inferior STEMI, and isolation RV infarction is extremely uncommon. These patients are very sensitive to preload, that is sublingual nitrates or nitroglycerin of any form, and they can develop severe hypertension in response to nitrate or other preload reducing agent. Hypertension in these patients is treated with fluid loading, and nitrate are contraindicated in these patients. So how you can spot right ventricular infarction from EKG, I have already given you a clue, but let's see it in another way. If there is ST elevation in V1, the only standard ECG that look directly at the right ventricle. If the ST elevation in lead 3 is greater than lead 2, because lead 3 is more rightward facing than lead 2 and hence more sensitive to injury current produced by the right ventricle. So these things on EKG strip will find toward RV and fault. In addition, there are some other things that can help you to detect RV and fault, and these are ST elevation in V1 is greater than that in V2. Or if there is ST elevation in V1 with ST depression in V2, this is highly specific for RV and fault. In addition, isoelectric ST segment in V1 with marked ST depression also point toward, and V2 also point toward possible RV and fault. So here, this is another strip, inferior STEMI with right ventricular infarct, and you can see that there is ST elevation in 2, 3 and AVF with the ST elevation in lead 3 quite greater than that in V2. In addition, there is ST elevation in V1 and there is ST elevation in V2 with ST elevation in V1 quite greater than that in V2. There are reciprocal ST depression in 1 and AVL. So this EKG also demonstrates inferior wall MI with associated RV and fault, and you can now confirm the RV and fault via right-sided chest lead. So here you do a right-sided chest lead EKG and you see that dominant R wave in V4 and it confirms your RV and fault. So now let's have a touch toward the anatomy of inferior wall MI. All of you know that inferior STEMI can result from occlusion of possible 3 coronary arteries. In 80% of the cases, it is the right coronary artery that is the culprit vessel. In 18% of the cases, it is the circumflex artery, the left circumflex artery. While in a very minor cases, the inferior STEMI can be result from a type 3 or wraparound left anterior descending artery. So vast majority, 80% RCA. 18% left circumflex, while in 2% of the cases it can be type 3 LAD or wrap around LAD that can cause inferior wall MI. So now how will you differentiate whether the inferior wall MI is caused by RCA or left circumflex on EKG strips? So there are certain patterns that will help you in that. ST elevation lead 3 greater than lead 2 point toward RCA occlusion. Presence of reciprocal ST depression in lead 1 and AVL point toward RCA occlusion. While if there is evidence of right-sided ventricular infarct, that is ST elevation in V1 and dominant R wave and right-sided V4, then certainly this thing will find toward RCA occlusion. Again, note it. ST elevation in lead 3 greater than lead 2. Presence of reciprocal ST depression and lead 1. Sign of RVN fault on EKG. Circumflex occlusion is suggested by ST elevation in lead 2 is equal to lead 3. Absence of reciprocal ST depression in lead 1. While there are signs of lateral infarction, that is ST elevation in the lateral lead, 1 AVL, V5 and V6. So this is a test case for you. You have to interpret this EKG strip the way I did it, and you have to write down your finding if possible in the comment section, and I am going to demonstrate the finding of this EKG strip in the next video I will have on anterior wall MI. Thank you for watching, and please don't forget to subscribe and click the bell icon to get notification of the next video that I'm going to upload soon. Thank you very much. Thank you very much for your precious time.